Good afternoon, ladies and gentlemen, and thank you for giving me the opportunity to speak here today. As Donna said, my topic today is the TB, or the pulmonary tuberculosis epidemic, which struck New York City from the 1970s to the 1990s. I will begin with an outline of the epidemic, followed by my reflections upon the determinants and the ethical aspects of the epidemic, in particular with regards to directly observed therapies. This graph shows the incidence of TB in New York between 1975 and 1995. After several years of steady decrease, there is a rise in the incidence of TB between 1978 and 1995. Hope you guys can see that. It starts from there to there. At the peak of the epidemic here in 1992, the incidence of TB was almost 4 times what it had been back in 1978. The fact that these TB rates did not appear to take off until the mid-1980s, sorry, something happened to the graph, was probably due to observer bias in that proper surveillance and monitoring programs were not implemented until the epidemic was probably already underway. So, what caused the epidemic? Well, many factors contributed, but the temporal association between fiscal cuts to public health funding and the epidemic was very relevant. Services which were vital for the control and eradication of TB were hit especially hard, as you can see from these figures. And in particular, I bring your attention to the last 2 figures. 50% of public chest clinics were shut down, and almost 90% of public TB inpatients were discharged. And furthermore, all publicly funded services specific to TB, so not just general chest clinics, were terminated. And these included both screening, diagnostic, and therapy programs. Subsequently, the TB rate skyrocketed. From this graph, we can see that the funding cuts at both the state and federal level both precede and coincide with the initial rise in the incidence of TB. Sadly, money alone can't explain away the entire epidemic. Many other factors exacerbated the outbreak and contributed to its epidemic proportions. The widespread displacement of residents, coupled with crowded shelters and jails, created perfect environments for the dissemination and transmission of TB. At the same time, the first outbreaks of HIV/AIDS in America significantly increased mortality and cross-infection. However, these are by no means all the factors that contributed, and there may well be many others which we simply don't yet know about. Another feature of the epidemic was the disproportionately more severe outbreaks in lower socioeconomic areas. In central Harlem, one of New York's poorest neighborhoods, the TB rate at the peak of the incidence was 222 per 100,000. Now, this rate was 100 times the average incidence of TB in New York at that time. In fact, this rate is comparable to many third world countries where TB is actually endemic. This was probably because poorer residents were most vulnerable to the factors behind the outbreak. For example, cuts to publicly funded TB programs disproportionately affected poorer residents who had no private health insurance. Displacement of residents caused by mortgage stress and cuts to public housing programs were also more prevalent in poorer areas. It should be clear from all this that public health determinants do not work in isolation. The factors directly contributing to the epidemic, such as cuts to TB services, displacement, or overcrowding, were influenced in turn by many other factors, such as financial constraints, poverty, crime, and even fires, which contributed to a lot of displacement. And finally, there may well be other factors which we, as I said before, we simply don't know about. Thus, it was this dynamic interaction between many different factors and not any one determinant or determinants on their own, which caused the outbreak to reach its epidemic proportions. We must respect the integrity of this complex interplay between different contributors and acknowledge, whilst we may not know everything about the outbreak, we must still be prepared to deal with an entire web of interconnected determinants. Now I would like to move on to the ethics of directly observed therapy, or DOT, which formed the cornerstone of New York's response to its epidemic. First and foremost, DOT clearly infringed on patient autonomy. However, flexibility provisions incorporated into the program minimize disruptions to patients' daily lives. For example, to dispense medications, healthcare workers met with patients at locations as diverse as homes, workplaces, and sometimes even subway stations. But when examined from a utilitarian perspective, DOT maximizes the good done for the wider community. Indeed, the current weight of evidence clearly shows DOT to be more effective at eradicating TB than self-administration, which is of great benefit to the community since transmissions and infections can be prevented more effectively. However, even in the time since I submitted my original application for the scholarship, a meta-analysis has turned up and shown that despite the increased compliance rates for patients on DOT, as opposed to those who self-administered, there was actually no difference in outcomes. There was actually no statistically significant differences in outcomes in terms of relapse, failure, or acquired drug resistance. Although this evidence is far from conclusive, the paradigm that DOT is the most effective method of therapy delivery is now being challenged. Therefore, we need to remain vigilant of new evidence and regularly and critically reflect upon our own practices. DOT also provides for a better context of care for patients. From a beneficence viewpoint, DOT was conceived in order to maximize the good that patients could receive from antibiotic therapy. In other words, DOT was designed to do the most good for all patients. In particular, this applied to patients who may otherwise not have taken the medication properly, such as the cognitively impaired or elderly patients. Furthermore, whilst DOT may not benefit those patients who would have otherwise taken their medications properly, it did them no harm either, except for the minor disruptions to daily lives, as discussed previously. Not causing harm to others may not sound like much, but often public health interventions can come with hidden and sometimes harmful consequences. For example, some countries routinely divide their restaurants and bars into smoking and non-smoking sections. Whilst this policy protects non-smoking patrons, it shifts the burden of secondhand smoking onto employees who are often non-smokers working in the smoking section. A balanced ethical approach is imperative for successful public health policies. To say autonomy outweighs utilitarianism or vice versa would be a gross oversimplification. Other, less notorious ethical perspectives, such as non-maleficence, should also be considered. Although the current weight of the evidence suggests that DOT is probably more beneficial than harmful, new evidence could change this at any time. Whilst we eagerly await more evidence on this matter, in the meantime, it is important to address the other aspects of TB as a public health menace. For example, socioeconomic factors such as access to care and population density. Ladies and gentlemen, I hope you can take away 3 points from my talk today. 1, we need to respect the integrity, public health determinants are very complex, and we need to respect the integrity and dynamic nature of these determinants. 2, public health is very ethically complex, and we must take a balanced ethical approach when considering interventions. And finally, evidence is changing and new evidence is emerging every day, and we need to be vigilant and continuously reflect upon our own practices. Thank you. Any questions? Mm-hmm. Yes.
And the social circumstances as well. So you've done a great job.
Thank you.
Any other questions?
Thank you.
What you raised in passing about the second-hand smoke and maleficence, and should be overt of second-hand smoke and
Yep.
fireworks. Partly true, but was that a negative? I just wanted to explore that a bit.
Well, I guess, well, I didn't want to focus on that because in Australia it sort of doesn't apply because we don't have. I'm not sure what the law is in New Zealand, but in all indoor areas in Australia, smoking is not permitted. Now, in some countries, including some of the heaviest smoking countries like China, they routinely divide their restaurants into smoking and non-smoking sections. Now, what I wanted to explore from ethically was that this DOT, directly observed therapies, actually did no harm to others who it didn't, to other people who were not directly involved. Whereas the secondhand smoking, it directly affected people who, were innocent. They were just bar workers, but they happened to get a shift, or they happened to get multiple shifts in the smoking section of the restaurant or the bar or whatever it is. So I wanted to explore it from a non-maleficence point of view, like not doing harm, as in not doing harm to others with your public policies, because that's what that policy was. It was a double-edged sword in some ways.
That was a good presentation. I just want to ask you about the competency elements that your investigation has addressed.
You mean in terms of the faculties?
Yeah, the faculty.
Well, I think first of all, I wanted to look at the determinants, the socio-economic determinants of public health, as well as the ethics of public health. I think those two were my determinants, and those as.
Any other questions? Thank you very much.
Thank you very much.